Hello. I bring you greetings from the Tata Memorial Hospital in Mumbai, in India, and I will be speaking to you on the management of sepsis in resource limited settings with a focus on fluid therapy. What do we mean by a resource limited setting? You might have a limited ICU infrastructure, you might have limited facilities for monitoring, limited therapeutic options, such as absence of facility for mechanical ventilation. You might have limited choices of drugs and fluids. There might be limited expertise, and there might be diseases peculiar to the environment and social and economic and cultural factors that make treatment in an intensive care unit or treatment of a critical illness fairly challenging. Now, this can happen in a country, it can happen in different parts of the country, or it can even happen in different parts of the same hospital where some areas are well resourced, whereas others are not as well resourced to handle critically ill patients. Uh, Now, the three pillars of management of sepsis include restoration of organ perfusion, control of infection, and modulation of the host response. And fluid therapy is an important step in restoring organ perfusion. The goals of fluid therapy would be to correct hypovolemia, restore tissue perfusion and oxygenation, and thus avoid complications related to hypoperfusion. However, it is important that we avoid complications of fluid therapy, which may be due to the volume of fluid used or the type of fluid used. Now, in the management of sepsis, the Surviving Sepsis Campaign guidelines are the sort of universal standard which most people would tend to use. And the guidelines state that sepsis and septic shock are medical emergencies and recommend that treatment and resuscitation begin immediately. And for patients with sepsis-induced hypoperfusion or shock, they suggest that at least 30 mils per kilo of crystalloid be given within the first 3 hours of resuscitation. If that means for a 60 or 70 kilo person, they're giving approximately 2 liters of fluid in about 3 hours. And this is sort of captured in the 1 hour care bundle, where it states that you should begin administration of 30 mils per kilo of crystalloid for hypotension or lactate more than 4 millimoles per liter, and use vasopressors if the patient is hypotensive. Now, how does this translate, these sort of aggressive fluid resuscitation strategies translate in resource-limited settings? Now, this is a very, very well-known and well-cited study. This was done in children with a median age of 24 months with severe febrile illness and impaired perfusion in Africa. Okay, so now these children with impaired tissue perfusion were assigned to receive either a bolus of 20 to 40 mils per kilo of 5% albumin, or a bolus of 20 to 40 mls per kilo of normal saline, or no bolus. If the children had hypotension, they were randomized only to either of the two bolus groups, but were not randomized to a no bolus group. Now, this was a unique setting. 57 patients had malaria, and children were treated in the general pediatric ward. Assisted ventilation other than short-term bag and mask ventilation was not available. The only monitoring that was available was oxygen saturation and blood pressure monitoring. So there was no invasive arterial pressure monitoring and no ventilation. Now, this study enrolled 3,170 patients. Out of most of them had impaired tissue perfusion, and they were randomized to an albumin bolus, a saline bolus, or no bolus. And to the surprise and shock of the investigators, we found that both the bolus groups were associated with a higher mortality as compared to the no bolus group. And this was statistically significant. It was significant at 48 hours, and the mortality at 4 weeks was also increased in both the bolus. So this trial actually showed that fluid boluses increase the 48-hour mortality in critically ill children with impaired perfusion in these resource-limited settings in Africa. And when they examined the cause of death and the presentation of the patients, they found that cardiovascular system collapse rather than fluid overload appeared to contribute to most of the excess deaths with rapid fluid resuscitation. This is another randomized controlled trial coming out of Zambia. There were 212 adults with sepsis and hypotension, and they were randomized to an early resuscitation protocol or a usual care protocol. Okay. They excluded patients who had a saturation less than 90 at baseline or who were tachypnic with a respiratory rate of more than 40 per minute. And almost all patients were cared for again on the general medical ward and did not have access to mechanical ventilation. Okay. They gave these patients in the early resuscitation protocol received boluses of IV fluid, and initially a 2-liter bolus followed by 1-liter boluses. And after every bolus, they monitored the JVP, the jugular venous pulse, the respiration, and the oxygen saturation. And they gave vasopressors and blood transfusion. Okay, so the only monitoring was oxygen saturation, respiratory rate, and the danger point was the jugular venous pressure. And if either the JVP was increased after the fluid bolus, or the respiratory rate went up, or the saturation went down, they stopped giving fluid boluses. And patients did not get more than 4 liters of fluid. This was also a sort of special case mix. Almost 90% of patients had HIV, and almost 46% had tuberculosis. And what they found is that with this protocol, the patients who received the protocol as compared to the usual care group got much more fluid at 6 hours, and at 24 hours, they got almost 3.5 liters in the first 6 hours. They got more dopamine, and they got blood transfusions as well, but that difference was not significant. So these patients received more fluid and more dopamine, more vasopressors during the ICU, during the hospital stay. And these investigators found that, again, the mortality was increased in patients who were randomized to the sepsis protocol group. So both these studies from Africa have shown that in settings without routine access to mechanical ventilation, the risks of IV fluid boluses seem to outweigh the benefits of patients who are acutely ill from infection. And in fact, so they both increased fluid boluses, and large volumes of fluid and aggressive fluid resuscitation protocol therapy increased mortality. Thus, the fluid guidelines that are developed from highly developed countries, like the Surveying Sepsis Campaign guidelines, may not be directly translatable to hospitals in developing countries, especially where facilities for monitoring and ventilation are not available. Okay? And while we admit that the results of these studies cannot be applied to high resource or well-resourced settings, it certainly casts doubts and increases the uncertainty regarding the ideal approach to IV fluid administration during early sepsis. Okay. Now, so is it okay to use lower volumes of fluid or lower boluses or slower boluses in these critically ill patients, especially in lower resource settings? Now, we have data from the recently published BASIC study, which was done in 75 ICU in Brazil, which is an upper middle income country. And they compared a slower infusion rate of 333 mils per hour versus a control rate of almost 1 liter per hour, okay, of the fluid challenge. So they gave fluid challenges either at a slower rate or at a faster or the controlled usual rate. And they found there was absolutely no difference in mortality. Okay, so it means you could use a slower rate rather than a faster rate, which is good in patients who are maybe prone to develop complications related to fluids, or if you didn't have enough monitoring or ventilation facilities. However, the mean fluid volume was only 1.2 liters, and therefore we can't really say whether this strategy would be safe in patients who require higher volume fluid resuscitation. Also, this was done in all critically ill patients, and only about 19% of patients had sepsis. Perhaps we could give slower rates of infusion, but can we get away by giving lower volumes of fluid to these patients with sepsis? And there is some direction provided by these two recently published studies called the CLASSIC study and the CLOVER study. And they both compared either a restricted intravenous fluid therapy to a standard or a liberal fluid resuscitation strategy. And in both these studies, they found that the restrictive fluid strategy was as safe and as effective as the standard or the liberal fluid therapy. And therefore, it would appear that you can actually use lower volumes of fluid in the hemodynamic optimization of these patients. However, it is worth noting that all these patients had received at least 1 liter of fluid prior to randomization. And in the classic study, it was almost 3 liters. So they had received a bit of fluid, the 30 mils per kilo bolus as over 3 hours as recommended by the Surveying Sepsis Campaign guidelines. So, but after that, restricting fluids seems to be safe and effective. So there is some direction given by these studies. The Surviving Sepsis Campaign guidelines suggest that you should use dynamic measures to guide fluid resuscitation over simple physical examination or static parameters. Now, if you don't have many of the monitors, then all you're left with is clinical examination, and the blood pressure, especially the diastolic pressure and the pulse pressure, do give you some information about the status of the cardiovascular system. A low pulse pressure suggests that the stroke volume is low, and increasing the pulse pressure after giving fluid suggests that there is an improvement in stroke volume. So you can give a small amount of fluid and see what happens to the pulse pressure. And if it improves, it suggests that the stroke volume may have improved. Similarly, a low diastolic blood pressure suggests that you need early vasopressors. And it suggests that the vascular resistance is extremely low, and you may need to use vasopressors to bring up the mean arterial pressure. Peripheral perfusion should be assessed clinically and can be assessed clinically. And you have three sort of windows. You've got the skin window, the brain window, and the kidney window. And cool extremity, a pale, clammy mottled skin, and a prolonged capillary refill beyond 3 seconds suggest that this patient has got impaired tissue perfusion. Similarly, mental obtundation and oliguria also suggest that the peripheral perfusion may be impaired. Okay. However, the mottling of skin may not be appreciated easily in dark-skinned patients. And if you see mottling in dark-skinned patients, you may actually mean that there is very, very significant hypoperfusion before you see that kind of mottling in dark-skinned patients. A mottling score has been described where, the greater the extent of the greater the spread of mottling, the worse is the tissue perfusion. And the response to therapy can be gauged by seeing that the degree of mottling is reducing. The capillary refill time is an important, simple tool which can be used, and a capillary refill time of more than 3 seconds suggests that perfusion is improved. However, the fluid challenge can be used without cardiac output monitoring, and this was described some years ago, where you gave a crystalloid at the rate of about 4 mils per kilo in 15 minutes, and you look for a clinical endpoint. If you had cardiac output monitoring, of course, an increase in cardiac output would be your clinical endpoint, but otherwise you could deduce an increase in cardiac output if the MAP increased, or the heart rate, the mean arterial pressure increased, or the heart rate reduced, or the urine output improved, right? And if that happened, you could stop giving fluid. Then there was a danger threshold, which would often be the central venous pressure. So if the central venous pressure increased significantly in response to fluid loading, you would stop giving fluid. In the absence of central venous pressure monitoring, then maybe something like the jugular venous pulse pressure or the fall in saturation might be a danger endpoint. However, these endpoints are not necessarily as reliable, but if that's all you have, then that's what you could use. It is important to monitor fluid responsiveness in septic patients, because about half the patients are not fluid responsive, and giving fluid to them would just increase the risk of fluid overload while not conferring any hemodynamic benefit. How do we use fluid? How do we determine fluid responsiveness? You could have tests based on heart-lung interaction, and these include the systolic pressure variation, the pulse pressure variation, or the stroke volume variation. The ones in red require cardiac output monitoring and therefore are not probably very good for a low resource setting. The pulse pressure variation is quite useful if you have a multi-para hemodynamic monitor. So also the end expiratory occlusion test requires cardiac output monitoring, and the tidal volume challenge can also be used with pulse pressure variation. The passive leg raising test ideally requires cardiac output monitoring, although pulse pressure monitoring may be a substitute for instance. A simpler way of using dynamic parameters would be the plethysmographic variation index, or the PVI, which is actually seen most often with a Massimo pulse oximeter, and you can get a continuous non-invasive measure of fluid responsiveness. So the pulse pressure variation again requires an invasive arterial pressure monitoring and a multi-para monitor. And if you have it, then you can use it to monitor fluid responsiveness without the need for cardiac output monitoring. If you have an arterial line and you're measuring pulse pressure variation and the patient is mechanically ventilated with a tidal volume less than 6 mils per kilo, you could use a tidal volume challenge, which consists of increasing the tidal volume for 1 minute to 8 mils per kilo and noting the change in the pulse pressure variation when you raise the tidal volume from 6 mils per kilo to 8 mils per kilo. And we have shown that if the change in pulse pressure variation is 3.5 or higher, then it suggests that this patient is fluid responsive even when receiving low tidal volume ventilation. If you have access to echocardiography, that's a fantastic tool to look at cardiac function, to look at the vena cava and all other areas. And inferior vena cava diameter changes during mechanical ventilation can be used to non-invasively and frequently look at fluid responsiveness. And increasing variability suggests increasing fluid responsiveness. Again, the patient needs to be mechanically ventilated. What are the endpoints of resuscitation? Again, the campaign's SSC guidelines suggest to use lactate, but they do say that it is okay to use capillary refill as an index of tissue perfusion. And this was shown by the Andromeda shock trial, where hemodynamic resuscitation guided by the capillary refill time was as good as resuscitation guided by lactate levels. So if the capillary refill time is prolonged, then a decreasing capillary refill time is an excellent and more sensitive sign than lactate of improving tissue perfusion. So real-time response to fluids is much better captured by the capillary refill time as compared to lactate. And of course, it is simple, it's easily available, and you can monitor the patient much more frequently and much faster and at almost no cost. So this is a very promising monitor of peripheral tissue perfusion. So depending on the options available to you, you can monitor the patients in the resuscitation, optimization, stabilization, or the de-escalation phases. Which fluid should you give? Now, if you should, of course, start with crystalloid, but if you need larger volumes of crystalloid, then the Surviving Sepsis campaign guidelines suggest using albumin, and we know that hydroxyethyl starches cause more renal failure and deaths, and therefore they are not recommended for the use in septic patients. Okay. The Surviving Sepsis campaign guidelines also suggest against the use of gelatin for resuscitation. And they suggest that you should use balanced crystalloids instead of normal saline for resuscitation. Now, this has significant cost implications in resource-limited settings. For example, in India, the maximum retail price, so the cost of normal saline is 35 rupees, whereas and ringalactate is similar. But if you used a balanced crystalloid like plasmalide, it costs almost 4 to 5 times as much. The gelatins and the starches, although not recommended, they are more expensive. They cost about 10 to 15 times more than normal saline. But albumin costs 5,000 rupees. That is, almost 70 times more expensive than normal saline or Ringer's lactate. Okay. Now, and these are moderately expensive and about 1/8 to 1/10 the cost of albumin. However, as of now, they are not recommended for use in septic patients. Now, after these guidelines have been published, we have the BASICS trial, again, which looked at balanced solution versus normal saline for fluid challenges and found no difference in outcome. And similarly, the PLUS study also found no difference in outcome when you use balanced versus solutions versus normal saline, right? So this means that we can use much cheaper solutions like saline, provided we're using moderate amounts of saline. This also raises several research questions which are applicable and should probably also be performed in resource-limited setting. Can we use smaller fluid boluses than the 30 mils per kilo? Why can't we use 10 mils or 15 mils per kilo for initial resuscitation? Can we use slower infusion rates for fluid challenges like in the BASIC study? Can we use lower volumes of fluid? Partly answered by the classic and Clover's trial, but they gave large amounts of fluid before randomization. Okay. We know that the starches are bad when given over a period of time, but if you give a small volume of starches for a very limited duration for the initial resuscitation, like it was done in the trial of Anand, is that safe and effective? And that would cut down on cost of albumin as well, but maybe that needs to be tried out. Is lactated Ringers cheaper balanced solution equivalent to the newer balanced solutions like plasmalide? So there's been no head-to-head comparison of these two balanced crystalloids. And finally, can capillary refill be used as an endpoint of resuscitation? And we'll probably get some information from the Andromeda Shock 2 trial. Okay, to summarize, crystalloid should be used for initial resuscitation. Bolus fluid resuscitation should be performed where facilities for monitoring, hemodynamic monitoring and ventilation are available. Slower infusion rates and lower volumes of fluid are probably okay. You can use normal saline in moderate amounts. It appears to be as good as balanced crystallide in moderate amounts. Starches and gelatin should not be used. Albumin is safe, but it's extremely expensive, and capillary refill time appears to be an attractive target of tissue perfusion. So thank you very much for your attention, and thank you for inviting me to speak on this topic.